Hello, dear listeners. Welcome to another episode of Follow Your Path. My name is Abdul Abid. I'm a surgical pathology fellow at University of Pittsburgh Medical Center, and today we will be talking to Dr. Kristen Atkins. She is a professor of pathology at the University of Virginia in Charlottesville. I'm also joined today by a future pathologist, Meredith Herman. Welcome to the show, Dr. Atkins.
Thank you so much. I'm so pleased to be here.
So starting off, can you please tell us a little about yourself, where you grew up, where you went to medical school, where you did your residency, and how did you end up doing breast pathology?
Okay, I'm happy to. So I grew up in Annapolis, Maryland, and I went to medical school at the University of Vermont. And I had a lot of classmates who were from California. And I thought for residency, it would be really fun to go to the West Coast, having been raised on the East Coast. And so I went to Stanford for residency. And I stayed there for a surgical pathology fellowship, and then came to Virginia at the Virginia Commonwealth University, or MCV, for a cytopathology fellowship. And because of my training at Stanford, I was really interested in GYN pathology. And I stayed at MCV VCU for 3 years total as faculty and doing cytology and GYN. And my husband was employed at UVA, and we looked all over the country for jobs that would put us in the same city. And we kept finding places that were great for one of us, but not for the other one. And we were this close to accepting a job in a really big city. And something opened up at UVA for me. And so I came to interview and I loved it. And I thought, I think this is going to be great for me. And at the time, Chuck Mills said, here's the catch. We need somebody to run breast tumor board. And I said, oh man, Chuck, I have not looked at a breast biopsy for over 4 years. And he said, that's okay. It's like riding a bike. You'll be fine. And he said, well, I don't want that to stop you from taking the job. And I said, all right, I'll give it a try. So I started UVA, and I'm walking to the first breast tumor board with Mark Wick. And he said, I'm really glad you're going to take this over. And I said, Mark, you need to know, I have not looked at a breast biopsy in the last 4 years. And he said, well, I'll help you. It'll be fine. And we start tumor board, and Mark says, wait, hang on. I want to introduce our new pathologist. This is Dr. Kristen Atkins, who has a particular interest in breast pathology. So that was my foray into breast pathology. And it turned out to be the best thing that could have happened. At the time, the breast surgeons had whittled down to 2. Their 2 other colleagues had left, and they were about my same age. And we kind of banded together, and we just got along really well. And I just enjoyed them so much. And then the breast radiologists were in need of a breast pathologist, and we started doing some research projects together. And they kind of became my people. And they were so happy to have one person who could be their point person. And just over time, it just became the thing that I loved. And I got to see every single breast cancer, breast biopsy that came through. I published with radiologists, with surgeons, with basic scientists, and your world suddenly just grows. And I think for me, it was just this big lesson, just for life in general, that you can plan all you want, but sometimes it's the doors that you didn't even really think were in front of you that can be so remarkable and lead to just real amazing life changes. And I wouldn't change anything. Now, if you were to ask me if I could only do one thing, I would say it would be breast path.
Wow, that is an amazing story of how that, kind of unfolded for you and fell into your lap. And, that is a great takeaway message there. So on your journey to pathology, was there a particular faculty member who inspired you down this career path, or, any particular specialty? You mentioned breast pathology, but any other interests that you had?
Oh, yes. So I did a post-sophomore fellowship when I was at the University of Vermont. And it was a big deal there. So there were 4 of us, 4 students who would do it every year. It had been, even when I was doing it, it had been around for over 20 years. So it was kind of one of those things where it was a privilege to do it. So it was a very competitive extra year. And I just loved the people who were there. I did it because I thought I wanted to go into HEMONC. And I thought that would be a great expertise to have, or to understand how laboratory medicine worked. And so that was my intention. And then when I left after that year and did all my other rotations, I just kept missing pathology. And I just found that what I love is teaching. And I enjoy patient care and forward patient interactions. However, it's the teaching that makes me so happy. And I just found that academic pathologists are often the consummate educators. And I think that's the part of it that I just really enjoyed. And I think I've almost come full circle and gotten back into a teaching trajectory. So that was really kind of it. And I thought I was going to do HEMPath. And just all during residency, HEMPath. And then I did a year with Peter Isaacson in London. I did a month with Peter Isaacson in London as part of an elective. And at the end, he said, Kristen, I'm going to tell you the difference between a good hematopathologist and a great hematopathologist. And basically, in a nutshell, what he said is that a great hematopathologist is meticulous and will pore over a slide and look at one cell on different antibodies and different tests and see what that one cell is doing. And they will pour their time and energy over it and will not be satisfied until they really understand the minutia. And I'm listening to this and I'm thinking, that's really kind of the opposite of me. And I thought, I think I've made a mistake. And I thought I'm really a more big picture person. And I like to do kind of 2x, 4x and and then move on. And it was probably, again, the best thing that could have happened. While I was disappointed in the moment, the more I thought about it and looked around at the hematopathologists who I admired, I thought, oh, they really are very meticulous individuals. And I just thought, I think I'm setting myself up for maybe the wrong trajectory. And so I went to my director at Stanford and I said, I'm having a little bit of a career crisis. And that's when he said, well, why don't you think about cytology? And because that's patient facing and it's kind of big picture and it allows you to stay broad and not focus in. And that was it for that part.
Oh, great. That's wonderful. And as you mentioned that you necessarily did not choose breast pathology, but breast pathology chose you. And now you've been in breast pathology for a while. So if you had to convince a medical student or a junior resident as to why breast pathology is a great field or what makes it unique, what would you tell them?
Yeah, so I think what I like about BreastPath is that, one, it's not easy. There are so many different entities and lesions, and they all get modified by the hormonal status and different medications and gender, and all of that then will change even the same entity. And so if you enjoy kind of more diffuse and more complexity to the way you diagnose, then BreastPath is for you. The other thing that I absolutely love about it is that it is truly interdisciplinary. And so again, for me, I really like collaborating. I like interacting with the surgeons and the oncologists and the radiation oncologists. And our tumor board is like, they won't have it if I'm not there. And the same for the radiologist and the radiation oncologist. And if one of us can't make it, it just gets canceled. Which to me just shows how important and integral each person and each part is to the final patient management. The other thing I love about it is that patient management isn't straightforward either. And as a pathologist, you can have a huge impact on how things unfold. There will be so often, one of the surgeons will say, Kristen, is there a lot of atypia or just a little bit of atypia? And I'll come back and say, this is making me really nervous that while there isn't maybe cancer in this margin, there's a lot of kind of precancerous things. And they'll say, okay, well, the patient's on the fence between a mastectomy and a lumpectomy. It sounds like you're really pushing for the mastectomy. And I said, I think that's in this particular case, I think that would be the wisest choice. Either that, or she has to recognize that she's going to have a lot more biopsies with atypia and find herself in the same situation. So it's just really gratifying to feel like I'm not just giving them a diagnosis, but really get to help weigh in. We also do a radiology pathology benign conference every week. And that's just with me and the breast imagers. And we go through all the benign biopsies and make sure that it correlates. And so much fun. And it's really low key. We're teaching the radiology fellows, we're teaching the path fellows. And again, it's a fun conference because we can say, oh, this is such a cool lesion, because we're not talking about malignancies, right? And so it's that just really is very cool too. The other thing that's fun about BreastPath is that there's a lot of research to be done, research from the basic science standpoint, as well as from common practices and how we manage patients with different lesions. And so there is so much to be looked into, and so many things where you as a practicing pathologist can change the way women are managed. And that's really exciting.
Yeah, definitely. Yeah, definitely. I find breast pathology so interesting because just a core biopsy, a little bit of tissue, that has such a big impact on the patient's next steps. And you really, hit the nail on the head with that, how important it is in the clinical care and management of that patient's life going forward.
Right.
So can you,
No, go ahead.
Yeah. So could you share a case with us that you found very impactful or interesting throughout your time as a breast pathologist?
Yes, I absolutely can. This happened about probably 6 years ago. And it was a situation where a patient had a diagnosis that we call lobular carcinoma in situ. And basically, it's just a risk indicator. And it's a risk indicator that both of her breasts are at risk for developing cancer sometime over the next 20 years. And it was surprising to me that she was sent to the surgeon and got that area excised. And I went to the radiologist and I said, why do you think they excised it? And he said, oh, because that's what the literature says should happen. And I said, not the path literature. And he said, well, the radiology literature says that LCIS should get excised. And so I thought, that's interesting. And so I looked at the path literature, and sure enough, there were a couple studies that had come out saying you don't need to excise it. And he looked at the radiology literature, and it all came back, you do need to excise it. And we kind of thought about it, like, I wonder why that is. And we found one article in which there was a pathologist and a radiologist involved. And their conclusion was, with good radiology pathology correlation, you don't need to excise LCIS. And we thought, let's do our own study. And so we did first a retrospective study, and I would wheel over the microscope to radiology. And there was a fellow who was the honest broker, so she knew all the follow-up information. And we looked at each case and we said, okay, what does this biopsy correlate for why you did the biopsy? And could she just go into the regular screening pool? And so he made the decision, yes, just keep her in screening. No, she needs to go to a surgeon for an excision. And by the way, I keep saying she because the vast majority of the patients are biologically female. So I do recognize that not every single person is going to be female who gets breast disease, but it's the vast majority. So getting back to this, so we found the same thing, that as long as we correlated together, we could safely just observe some of these patients. And what I found was that our path reports were woefully incomplete. So it wasn't giving the radiologist enough information to make that assessment. And that is why in the radiology literature, they were just going off the path reports. And in the path literature, they were actually reviewing the slides and being more comprehensive. So we actually changed the way we manage patients here. And this is now, we've spoken around the country, we speak at radiology meetings, and actually 2 of us just spoke at the Society for Breast Imaging this last spring, again, on this exact topic. And we now have a prospective trial going and kind of find the same thing. And this has been going on for years now, where it's just, as long as we have good rad-path correlation, you don't need to excise. And so the reason that's so exciting is that it's just kind of a, not mundane, but it's a very common diagnosis that because we started questioning things and because we had good collaboration, we did a little study from it. And the coolest thing from it is that it came down to communication, which I think is very cool, right? We don't need an antibody. We don't need any fancy testing. This is just communicating, and you can really change the way somebody is managed. And so that, like, for me, is kind of probably one of the pinnacles of just like, wow, you can really impact people's lives, not just on an individual level, but from a whole population standpoint. And so that's pretty cool.
Yeah, wow.
Wow.
And you have mentioned at just the last answer and before that, you mentioned what you find really fun and gratifying about your job. But again, I'm going to ask you specifically, what do you find is the most gratifying aspect of your job?
Oh, just my job in general, or
As a breast pathologist?
As a breast pathologist. I think what I love is that when I put the slide down on the microscope, in a 0.2 seconds, I have an idea of what it is. Maybe I don't know the exact diagnosis, but I can tell that this is benign, or I can tell this is malignant, or I can tell, oh, this is somewhere in between, and I'm going to need to take a little time. And having that kind of almost spinal level of diagnostic ability is just so fun. And then you try to figure out, like, what is it that I'm picking up on? And now how can I teach this to somebody else? And how do I get them as excited and being able to maybe work through it in a clunky way first, and then start gaining that same kind of almost like primitive brainstem recognition of what you're looking at. I mean, my guess is that most pathologists would say they enjoy that. But breast path is just so fun, because as I started off by saying, is it so vast and so many different things that can impact what you're looking at. And so it just takes lots of repetition and lots of different scenarios. And it's just very exciting to be able to know that, to feel like I think I'm trustworthy. I think I can, that I'm going to do the best that I can for this specific patient. And then I'm also going to try to work really hard with the generation coming underneath to get them to that same point. So I don't know, that's not a one answer, but as I said from the beginning, I kind of like big picture kind of days. And so just doing one thing would probably bore me. And I like the teaching. I like the administration. I like the QA. I like the interpersonal stuff with the clinicians. And every so often I have a patient who wants to come and look at their specimen or wants to look at the slides. And I love doing that. Colleagues, unfortunately, the older you get, the more your friends and family are going to have breast cancer. And so then being able to talk to them and really try to get them to understand the gravity, or maybe yes, this is a deal, but it's maybe not such a big deal. And being able to help people kind of navigate that is just really fun.
And that is just amazing. It sounds like you have one of the best jobs in the world.
I really feel like I do. Most days I kind of walk in and I used to think like I have the best kept secret. Right? And I am,
Totally.
I've been doing this for 25 years now, and I still love it. And it changes, right? And I'm part of a clinical trial now with a breast surgeon, and we're looking at what happens when you have hormonal treatment before surgery. So if you have basically like tamoxifen for 3 months beforehand. And so we're coming up with a way to assess the pathology, and that will that then be predictive of whether they need radiation or that they're responding to the tamoxifen. And so it's just really exciting, right? There's just constant new things to get involved in.
Definitely. I guess that leads me to my next question about training and how do you get into breast pathology? And what is the training like? Is there a fellowship? Is there a board exam? Can you kind of walk us through that?
Yeah, absolutely. So let me just say that when I got into breast path, as I told you, by being voluntold and showing up at a tumor board, that is not the typical course. And when I was coming through, there really weren't breast pathology fellowships. You could do like surge path fellowships and then focus on breast and that sort of thing, but it wasn't a dedicated fellowship. And now there are set breast pathology fellowships. There are also combined fellowships. So a lot of GYN, there's GYN and breast path fellowships. That's what we do at UVA, is we combine it. And then depending on the fellow, on how interested they are, they can amp it up or tap it down depending on how interested they are. You don't have to have a breast fellowship to do breast path. It's not boarded at the moment. And I do think, though, if you're going to do breast path, you need some immersion in it, whether it is doing like a little mini fellowship during your residency, or if you're doing a surge path fellowship, of doing a little more focused time, because it's just gotten very complicated and lots of things to keep in mind. And I think you really want to rotate with the radiologist and the radiation oncologist and really get a handle on what's happening and where the decision making is happening, so that you can be a really good steward to the group.
Oh, that's good to know. So last question, what advice do you have for medical students and residents who are interested in breast pathology? What should they do during their residency to sort of like, and I think you have already mentioned like doing a mini fellowship, but anything else that they could do as part of their residency training to help them?
I think the big thing is it can be a little frustrating at first. For instance, I give an entire hour session on just differentiating hyperplasia from low-grade DCIS, right? Like that's an entire hour. And we have a sound bite that goes into like a little learning thing that they can listen to that's 10 minutes long, going through that same thing. So just some of the most basic diagnoses can be extremely challenging. And I think for some people that it'd be a little frustrating, right? Because that same feeling that I was just talking about of knowing what you're looking at, we're all looking for that, right? We want to feel competent and we want to feel like we know what we're doing, and you're not going to get there quickly with breast path. So it's more just kind of thinking, all right, I'm up for the challenge and I'm going to chisel away at this. And you just have to start almost like path itself, right? You just have to take one little piece, work at it. And then when you start to get competent at that, you're going to kind of start expanding. I would also say that go to the tumor boards early. So start understanding the clinical consequence. Excuse me, let me just turn that off. All right, I'm going to restart that. I would also say, go to the tumor boards and the interdisciplinary conferences, even if you're not the one presenting. In fact, it's almost better if you're not the one presenting, because then you're not feeling the pressure of presenting the path well. And instead, you can just focus on, okay, how is the path impacting the conversation? And because then when you're signing out your case, you know that, okay, this is a grade 1 cancer. This is what's really important. This is a HER2 amplified tumor. This dimension is actually, or this stage is really important. Or, oh, this is a positive node in an ER positive patient, and I just heard them talk about this new chemotherapy. I know I need to add this test to it. I often tell the medical students who rotate on path when we do our breast session, I say, here's the thing that's going to happen. You're going to ask me a question, and I'm going to go like this. It depends. And that basically defines breast path. And so you just have to be cognizant that one answer is not going to fit all scenarios. And so, yes, you have an invasive cancer, but is it a grade 1 or is it a grade 3? Is it ER positive? Is it HER2 amplified? Is it stage 1? Is it stage 3, right? Like all of these things, is she under 70? Is she over 70, right? All of these things are going to impact what gets done next and what goes into the management. And so that can sometimes feel overwhelming, but it's also really exciting because the same things keep coming up and you start seeing that like, oh, okay, there is an algorithm going on here. There are some things that are consistent. There's just more options and more variables that are taking place. So I would just say, even if you don't end up being interested in breast path, you're going to know people who are going to have breast cancer. And they're going to come to you and ask, what does this radiology report mean? What does this pathology report mean? And if you have a really good foundation, you are going to impact and be super helpful to your family member or to your loved one or to your friend or your colleagues, spouse, like all of these things, it's going to happen. And because you're empath, they're going to look to you. And it's kind of like colon cancer, right? So breast, colon, lung, right? You are going to be in the situation of helping people who are close to you, even if that's not your discipline. So I think it is in everybody's interest to at least understand the foundation, understand the clinical correlation, and also just understand that like probably one of the most helpful things that you can tell the person that whoever you're discussing this with is that don't make up your mind, right? Don't say what you're going to do or not do yet. You need more information, right? Because things come in piecemeal, and people will hear the word cancer and breast and just say, well, I'm not going to have a mastectomy or I'm not going to get chemotherapy, right? They just do that. And so it's just nice to be able to say, you know what? Don't make any decision. You don't know. You need to meet with different people. You need to find out more stuff about your tumor, and you might change your mind. So this is not the time to dig your heels in the ground. And so if you have that understanding, you're going to really, really be extremely impactful in people's lives, even if it's not your area.
Oh, wow. That's amazing. That's inspiring to know, Dr. Atkins. And that's our show for today, folks. Thank you for listening to us. You can find Dr. Atkins on Twitter as well, and she's a frequent user. Her Twitter handle is @Kristen_Atkins. And if you like the show, please like and subscribe to our channels on YouTube, Apple, and Podbean. We'll be back with another episode soon. Thank you.
All right, I'll stop recording.